the effective risk mitigation guidance on mortality and acute care visits. I'd like to start us off by acknowledging colonialism in the past and the present. We come together in this community of practice from across Turtle Island as people who live on treaty lands and ceded and unceded territories. Our team and community of practice members are comprised of individuals and organizations from across Turtle Island. We are all treaty people. We work in a sector whose goal is to address the social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking in our ongoing daily lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today, and we commit to working in ways that transform racist and colonial institutions and practices, to repair harms, prevent future harms, and to work towards a more inclusive and equitable future. I invite you to put your name and where you're joining us from today in the chat. It's great to see who's here and joining us today. So welcome, everyone. We will be recording this event and we will be sharing it on our website. We will have the slides to share as well. A note about technical difficulties. If you are having any technical difficulties, honestly, the best way to handle it is to log off and then rejoin the call. Sometimes that does some kind of magic that makes it all work. We have closed captioning available in English. You'll find the button on your Zoom panel there at the bottom of your screen. You'll also see that there's a chat box and a Q&A box. The chat box is a space where you can interact with other people who are here listening in and attending at this call. The question and answer box is a place for you to put your questions for our presenters today. Putting it in the question and answer box lets us keep them separately, make sure we don't lose them in the chat. Sometimes the chat's very, very busy. We also have a certificate of attendance that we can make available for you. We'll put a link into the chat box about halfway through, and that'll take you to a form that you fill out, and you'll get an email with the certificate. I skipped over this slide by mistake. I just want to go back to it because I want to make sure that people who aren't familiar with the community of practice know who we are and what we do. We are funded by Health Canada's Substance Use and Addictions Program, and we're a collaboration of organizations, including London Intercommunity Health Centre, the Canadian Association of People Who Use Drugs, Alliance for Healthier Communities, and the Ontario Aboriginal HIV/AIDS Strategy. The focus of our work is to support the scale-up of prescribed safer supply programs in Canada. We focus on a medical model because that is the most feasible model in our current regulatory and legislative context, but we also support advocacy for non-medical models and decriminalization. That's a really important part of the work that needs to be done to address the needs of people who use drugs. We have a number of resources, protocols, evidence briefs, archives of our webinars that you can, and many more things that you can find on our website. I encourage you to visit our website to see those resources and also to find how to join the community of practice. We have a few things coming up I want to draw your attention to. At the end of the month, in a couple of weeks from today, we have a presentation, a webinar on the ethics of prescribed safer supply. We have Dr. Alice Varani coming, who was involved in the recent report, the ethics report component of the report from the Provincial Health Officer's Office. And then we also have Daniel Buckman coming. Daniel's a bioethicist at the Joint Center for Bioethics at the Dalai Lama School of Public Health. And Dr. Adrian Gruda will be moderating this. It'll be a great discussion. I'm really looking forward to this webinar as well. And we're having a big celebration on March 21st. We're bringing our community members together to celebrate the work that the community of practice has done over the past 3 years. We're really happy to have Carrie Wendell McClelland facilitating this. Carrie's an amazing facilitator and performer, and we expect this celebration to involve lots of music, art, storytelling, and just really celebrating what happens when you bring a bunch of an interdisciplinary group of people from across the country together to talk about how to make the world a better place for people who use drugs. So hope you'll join us for that. Again, I encourage you to come to our website to find out more. You'll find links to register to our events there as well. And my colleague Robin has also placed them in the chat. I'm going to stop sharing my screen now. And I'm really happy to turn this over to Karen and Brittany. I'll have you start with introducing yourselves and then take us on the journey of the study that you're sharing with us today. Thank you.
Thank you, Rebecca. Hi, everyone. I'm Karen Urbanowski. I am an associate professor in the School of Public Health and Social Policy at UVic and a scientist at the Canadian Institute for Substance Use Research. I am a settler of mixed British and Ukrainian heritage, and I am gratefully joining from the unceded territories of the Lekwungen people, specifically the Songhees, Esquimalt, and Wasanich First Nations in what is colonially known as Victoria, BC.
Thanks, Karen. My name's Brittany Barker. I'm super pleased to be here with you today. I'm a settler as well of mixed European ancestry. I'm gratefully calling in from the unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations in what is colonially known as Vancouver. I'm a senior scientist with the First Nations Health Authority, as well as collaborating scientist with the Canadian Institute on Substance Use Research. Yeah, and just really grateful to be here with you all today, and I'll pass it over to Karen. I'm going to share my screen. Let us see. Good.
Perfect. Thank you. Okay, so we are very excited to be here to share a little bit of our research with you all. The title of our talk is Effective Risk Mitigation Prescribing, colloquially known as Prescribed Safer Supply, on mortality and acute care visits using population level data in BC. We are superstars at coming up with titles, clearly. So this is one part of an ongoing evaluation research project that's been looking at some of the prescribed safer supply models that have been popping up in BC since 2020. And so Brittany and I are going to be speaking today about a paper that was recently published in the British Medical Journal, and we'll walk through that analysis and some of what we found. Next slide, please. Want to acknowledge that we had funding from a number of different organizations to do this research, including the Victoria Hospitals Foundation, the Michael Smith Health Research BC, and CIHR for doing this work. And you can see all of the logos on the bottom. We're a big team of over 30 research scientists, support staff, folks with lived and living experience of substance use who came together, bringing all of our different disciplinary knowledge and expertise to answer some questions around the implementation and impacts of these different forms of prescribed safer supply since the onset of the pandemic. We'd like to acknowledge that while we've shared where we're joining from today, this work itself took place in the traditional unceded and occupied lands of the over 200 First Nations across British Columbia. And we specifically acknowledge and we grieve the disproportionate impact that the toxic drug supply crisis continues to have on First Nations, Inuit, and Métis peoples as a direct result of the historical and ongoing impacts of colonization, as Rebecca alluded to earlier. Okay, so to get started, what we're going to talk about is one small part of the larger evaluation that we're doing, and you will be seeing publications coming out from our team and different knowledge translation products coming out around the different parts of this study. But just for this one part that we're going to talk about here today, the objective of the analysis was to determine the effect of opioid and stimulant prescribed safer supply under the Risk Mitigation Guidance on all-cause and overdose-related mortality and recurrent acute care visits. So I imagine that this crowd, you'll be probably pretty familiar with the BC's Risk Mitigation Guidance, at least in its initial iterations. I wanted to acknowledge that the data that we'll be speaking about come from 2020, 2021. So fairly early on through the implementation of this form of prescribing. And so what we're talking about here in terms of medications is primarily tablet hydromorphone for opioids. But that could, the prescribed opioids did vary somewhat across the province to also include sustained release oral morphine or MS-LON, as well as oxycodone in some programs, but we're primarily talking about tablet hydromorphone. For stimulant prescribed safer supply at this time, we're primarily talking about dexedrine or methylphenidate. Those would be the medications that folks would have received. Those medications constitute the exposure or the intervention that was prescribed to them, and we are looking for the outcomes of receiving those prescriptions. And our outcomes for this part of this study were overdose, all cause, so any cause and overdose-related mortality, as well as the acute care piece. Next slide. Okay, so as to give you a bit of a spoiler alert of where we're headed over the course of this presentation, these are our key findings in a snapshot. So the takeaway messages here. We identified 5,882 people in BC who were diagnosed with an opioid or stimulant use disorder, received one of these prescriptions. And this is between March 27th, which was the day after the Risk Mitigation Guidance was published, March 27th, 2020, I should say, and August 31st, 2021. That was our study period. These 5,000, roughly 6,000 people, were matched to a sample of comparable people who did not receive a prescription. We found that risk mitigation opioid prescribing was associated with a significant reduction in the likelihood of death among people with an opioid use disorder. So for example, risk mitigation opioid prescribing was associated with a 61% reduction in death from any cause and a 55% lower risk of death from overdose, which is fairly substantial. We found that this protective effect, so this reduction in mortality associated with receiving one of these opioid prescriptions actually increased with the number of days that people got a prescription. So sometimes in research, this is called a dose response effect. People who received more days of a prescription, so 4 or more days specifically, had a 91% lower risk of death. So that protective effect increased there. Prescribing stimulants was not associated with a statistically significant reduction in the likelihood of death. We'll come back to that a little bit and hopefully have a bit of a conversation in the Q&A, but the findings do indicate a protective effect, but it was not statistically significant for the stimulant prescriptions that were given at the time. Risk mitigation opioid prescribing really does from the results of this study, if we have one takeaway message, it's that it's a promising intervention to keep people alive. That's it in a nutshell. Next question. Sorry. I'm going to walk through some methods now, and we'll go through as plain language as I can, and we can come back to any questions that folks have toward the end. So our data source for this particular study was linked administrative health data from a cohort of all BC residents with an indication of opioid use or stimulant use disorder during the period from January 1996 to August 2021, when our study period ended. So administrative health data, as many of you will be aware, is the data that results whenever your healthcare card is swiped. So this is the picture of the back of a BC healthcare card, and the personal health number is there. That's not my personal healthcare number. It might be Brittany's, I'm not sure. We'll have to check. The data are linked across data sets using this number so that we're able to identify people and piece together their trajectories of health service use over the study period. Next slide. These are the data sources or the databases that we had available to us for this study. So physician billing records available through the medical services plan. In Ontario, this is the OHIP plan. We had data on hospital admissions. In BC, we have a fairly robust data set that captures any dispensations of medications at community-based pharmacies, so pharmacies outside of hospitals. When you go to pick up your prescription medications, we have that in a database as well. So that obviously we really needed that in order to be able to do this study because our intervention is prescription-based. In addition, emergency room visits and mortality was our main outcome was assessed using both BC Coroner's Service and Vital Statistics data sets. Okay, so we did a fairly in-depth statistical analysis of this data set. So the first key point is that we used a matched one-to-one comparison. We created a control group using two different approaches. So each person who was dispensed an opioid or stimulant prescribed safer supply medication was matched to a person who did not receive prescribed safer supply. This control group was created so that we could measure outcomes on people who did receive a prescription and people who didn't receive prescriptions, and we could compare those two to see how they differed. When you do a study of this nature, you really want to be comparing apples to apples. We want to be able to know that our control and intervention groups can be compared validly, so that we know, like, can we rule out as many alternative explanations as possible as to why they might differ on mortality or why they might differ on acute care. So we did this in two different ways. We ourselves as a team came up with a number of potential confounders and matched people on those using a propensity score matching technique. And we also used machine learning to identify 50 potentially influential confounders, which we then combined with our own confounders that we identified as researchers with expertise in this area, and use that to match people as well. Obviously, one really important confounder, which we've been speaking about quite a bit since this study was published, was that we had to control for people who received opioid agonist treatment. So co-prescription was high between OAT and prescribed safer supply in this cohort. It wasn't 100%, but it was common. We wanted to be able to draw conclusions about whether or not any effect that we were seeing of prescribed safer supply was actually due to those tablet hydromorphone pills and dexedrine and the like. So we looked at the receipt of a prescription and then the next week, what happened. So you received a medication in 1 week, what happened the following week? And the reason we use such a short time frame is that the medication is only going to work as long as you take it. Obviously, this is very common within harm reduction interventions, is that we don't expect them to have a long lifespan after people stop using them necessarily. We want to see the immediate impacts of them. And so we used a technique called marginal structural models. And we use that weekly steps of comparison to measure the effects of prescribed safer supply dispensations on outcomes in the following week. And with that, I will hand it over to Brittany to walk us through what we found.
I'm so glad you did that part. Great job. Yeah, and I just would pick up and say that, for most medications, their effectiveness is only while you're taking them, right? So birth control, you stop taking it. Oops. Blood pressure medication, lots of other medications. So thanks, Karen. Okay, I'm going to take you through some of the results, even though there was a bit of a spoiler alert in the beginning. To start with, 5,882 people in the province were dispensed either an opioid or a stimulant safer supply medication in the first 18 months of the intervention. Now, to a lot of people, that sounds like a lot. However, I do want to qualify this with that is less than 6% of the total estimated population in BC with a stimulant use disorder or an opioid use disorder. And that's people with indications of stimulant and opioid use disorder and the intervention only got to about 6% of them, okay? Of this 5,882 people, the vast majority received an opioid safe supply prescription, which, as Karen said, the vast majority of those were hydromorphone tablets or DILIs. 18%, or about 1,000, received a stimulant safe supply medication. And this, I'll come back to why this is important when we go over the results. And then 535 people were dispensed both a stimulant and an opioid safe supply medication during our study period. Okay, so next I'm going to move to some demographic and health service characteristics of kind of what we call the patient profile, or the patient profile in the sample. And 40% of the clients were female, the other 60% were biological male. We don't have gender in administrative health data, so it's limited in that sense. Almost 90% of the people who received the intervention lived in an urban area. And that's really important when we think about the way that this was supposed to be implemented. It was supposed to be rolled out through like primary healthcare, any doctor could, but where prescribing actually happened was very much concentrated to urban areas, which is Victoria, Vancouver, maybe Kelowna. Almost 90% had been on income assistance in the past year. Almost half had an indication of an alcohol use disorder in their health records. Over a quarter had a chronic pain diagnosis within the past year. 40%, just over 40% had unstable housing, and that would be an underestimate because that would only be if your doctor knew that, or if it was somehow disclosed to a healthcare professional, right? And then coded in a record. So, and then 9% were incarcerated in a provincial correctional facility. And I want to qualify that we don't have federal corrections data, so that would also probably be an underestimate. All of this to say that this population was RMG, or prescribed safer supply, was reaching a highly marginalized, potentially street entrenched population of people who use substances. Okay, let's go to the findings. Oof. I'll try not to make this really boring and sciencey. Okay, so these things, the dots are called point estimates, and the bracket thingies are called confidence intervals. And this dotted line over 1 means that there's no effect. And so if things are below the dotted line, then that exposure is considered protective against whatever your outcome is, which in this case is all-cause mortality. If it was over here, then it's a risk factor. And so what you see is that 1 day of opioid prescribed safer supply was associated with a reduction in hazard for all-cause mortality by 61%. And that range of certainty we had, the confidence interval, is between 46 to 78%. And then what we found was also that more days, so people who received 4 days or more of opioid safe supply was associated with reduction of all-cause mortality in the next week by 91%, with a range between 79 to 96%. And so this is, I think Karen's already mentioned, that dose response, or that biological gradient that we're expecting to see, so that more of the intervention equals a greater level of protection against death. Now, I do want to point out this one. So as Karen mentioned, not a lot of people who received opioid safe supply hadn't had OAT in the past 30 days. In these estimates, we controlled for OAT at weekly time steps. But we wanted to be really sure that what we were seeing was an isolated effect of hydromorphone tablets or opioid safe supply. And so we also did a sensitivity analysis where we excluded everyone who had been on OAT in the past 30 days. This left very few people. And so you get this wide confidence interval because we can't say for greater certainty that there just isn't enough people essentially in that. But the point estimate is still trending in the right direction. So all of this taken together, when you look at the picture, is pointing to a more robust finding. Okay, let's go to stimulant safe supply, dispensations on all-cause mortality. these are not statistically significant because, again, these confidence intervals cross 1. However, so we did find that if you're looking at the point estimates, 1 day or more of stimulant safe supply was associated with a reduction in the hazard for all-cause mortality in the week following by 50%. However, that range is up to an 80% risk reduction to a 23% risk increase. And the same way with the 4 days or more of stimulant safe supply was associated with a reduction of 61%, but the range is 39% risk reduction to 89% risk increase. And that's largely because we were just underpowered, right? So we only had 1,061 people in this group and shorter time frame, and we'd need to have more people who are receiving the intervention to say with greater certainty that we are seeing a protective effect to shrink those confidence intervals. Okay, so now let's move to opioid safe supply dispensations on overdose mortality. So same thing that we saw with the all-cause mortality, the point estimates are trending in the right direction. Everything is on the protective end. And we found statistically significant findings that receipt of at least 1 day of opioid safe supply was associated with a reduction in overdose mortality the week following by 55%. The range was 27 to 75% risk reduction. 4 or more days of opioid safe supply was associated with a reduction in the overdose mortality hazard by 89%. And so this taken with the other one on all-cause mortality is just, it's building more that the findings of what we're seeing, we can be more and more certain about them and say more about them. But again, you've got that group who, very small number of people who hadn't had OAT within the past 30 days. And the point estimate is still in the right direction, but it's a statistically non-significant finding because it's such a wide confidence interval. Okay. The impact of stimulant safe supply dispensations on overdose mortality, again, not statistically significant. Point estimates are trending in the right direction, but those confidence intervals are really wide. Okay, so next we'll move to the impact of safe supply on any cause acute care visits. And at the top, we have this box is for opioid safe supply, and the bottom is for stimulant safe supply. So we'll go with opioid safe supply first, and it's not statistically significant. And unlike the other graphs I showed you, like the point estimates are all over the place. Some will look like it might be a risk factor, some don't. So we can't say anything about the impact of opioid safe supply on acute care visits the next week. Down here with stimulant safe supply, oddly, we can. So it did reduce acute care visits in the following week by 18% for those who had received stimulant safe supply. And that range was between 5 and 27% risk reduction. And then those who received at least 4 days or more of stimulant safe supply, the next week, their odds of acute care visits went down by 19%, or a risk reduction between 7 and 30%. So some limitations. We are unable to determine if people who received the medications consumed or took them as prescribed. Diversion. I'm going to come back to this. The other thing we are unable to say is that there was a limited time period. We only had the cut of data for the first 18 months, about 1.5 years of the intervention. On Monday, we just received the new cut of data to the end of 2022. So we will be able to update these with a much longer time frame. Exciting things coming for us. Now, going back to the diversion thing. So we are unable to determine if people consume the medications they were prescribed. And there has been some people who have talked about maybe this was an income effect, right? People are selling their dillies and then they're getting that money and they're doing things that are making them weller, and that's what we're seeing. Well, maybe, although, you know, dillies go for less than $1 in the downtown east side and in Vancouver and in most of British Columbia, and you only get 14 a day. But you wouldn't expect to see that biological gradient, right? It wouldn't be 4 days or more, wouldn't have that big of an effect in the week next on mortality if it was just an income effect. It just wouldn't happen. Plus, it's a population level study. It's very unlikely that this is a diversion effect. And we are doing a lot with our evaluation and moving forward to keep on monitoring for diversion. But for this evidence, it definitely doesn't show that there's a diversion here. The other thing I wanted to say was the limited time period. We had a limited sample size of about 5,800 people and the time period, and some things are relatively infrequent outcomes like death. So these challenged the confidence intervals and made them quite wide, which is what we saw in the stimulant safe supply results. Some strengths of the study. This is the first population level ascertainment of prescribed safer supply dispensations and outcomes on outcomes, so acute care utilization and death. This is linked administrative health data used to construct a robust comparison group matched on 50 variables that wasn't human biased. This was machine learning. And I was watching Bodan, one of our other study leads, talk about what they were matching on. It was like matching on people's cellulitis in hospitalizations. So, you know, if you're matching someone on 50-50, going back to what Karen said about like comparing apples to apples, we were comparing apples to apples. And again, this is the first known population-based study to measure the impact of safe supply on mortality and healthcare utilization. And that's because British Columbia was the first jurisdiction to roll out a prescribed safer supply program. So here's the hierarchy of medical evidence, which is used quite a bit in how we determine rigor and bias in a study. And so at the bottom are expert opinions, which we've heard a lot of around safe supply, case reports, and then cross-sectional studies and surveys and interviews. And this is where the current evidence base for safe supply exists. And that was just because there were limited pilot programs and British Columbia was the first to be able to open up. Our study is up here in the cohort studies, which the only thing higher is a randomized control trial, but that would be super unethical to do and not possible. And it's a cohort study, but I do want to say that it's people can't self-select in. This is just, we have all your healthcare records because of our research. So it's much more robust, and our findings are more robust because of them. No other study and any of the other evidence that's been produced around safe supply had an unexposed control group, and no study was provincial in scope. So key messages: receiving opioid safe supply for one or more day was associated with 61% lower rates of death by any cause in the following week. Receiving opioid safe supply for one or more days was associated with 55% lower death rates by overdose in the following week. There it goes. And then going back to that dose response, receipt of 4 or more days of opioid safe supply was associated with a 91% reduction in death rates of any cause and 89% lower rates of death by overdose in the subsequent week compared to a matched people with an indication of opioid use disorder who did not receive prescribed safer supply. So again, going back to that apples to apples. One of the things we didn't show you is our sensitivity analysis around higher doses of opioid safe supply, just because it was a lot of graphs. And what we found was that the longer a person was on opioid safe supply, which we did show you, and the higher the doses of opioid safe supply, the more protection from dying, indicating this robust kind of dose response relationship. And now I'm done. Great, thank you. And I guess we'll take questions. I'll kill this.
Amazing. Thank you so much. If you do have questions, then do put them in our the Q&A box for us. I'm going to just quickly launch a poll so we can grab some statistics from our attendees for our for our funders. So if you could just take a moment to complete this poll, and also put your questions in the chat, or sorry, not in the chat, in the question and answer box, please. That way we can keep an eye on them. And Brittany, can you just share your screen, and then we can have a look at what
I'm trying to, sorry. And
Oh,
now my
there you
dog's
go.
barking too,
Well
just to
done.
make it super fun. Sorry about that.
So I have lots of thoughts, but we do have a couple of questions in the Q&A box already. So let's start here. Someone's asking, if someone was receiving PSS, would that have been continued in hospital? Wondering if the RMG prescribing reduces healthcare avoidance among people who use drugs, knowing they would have their needs met in hospital.
What a fantastic question. So as it happens, I was just having this discussion with someone this week. And so when I mentioned the PharmaNet data set, which we're using to identify whether or not someone was receiving one of these prescriptions, that's community pharmacies. So the prescriptions received in hospital aren't captured there. They're also not captured in the hospital data sets that Canada uses through CIHI either. So I dug around a little bit, and some of the health authorities or health regions in BC capture this data in their hospitals, but it's really not available. And so I believe there's a group in Ontario through Dr. Tara Gomes, who wants to start trying to figure this out and piece together what happens when folks go to hospital. But I will say that from the other parts of our evaluation where we're asking people for self-reported data, they're not getting continued.
Yeah, that's a big issue.
For many.
I know that there's so much interest in pushing that work forward into working with hospitals to find out how do we keep people keep their retention in care, which also helps them stay in hospital and get the other kinds of care they need. So yeah, great question. Thank you. Brittany, did you want to add anything, or shall I go to the next question? Okay, another question here is someone saying, can you talk a little bit more about how the matching worked around OAT prescriptions? Was OAT dose controlled for? I've seen a lot of chatter about that aspect of the study on various listservs, and I'd like to understand it more. Yeah, it's another really good question. We are seeing lots of great comments about and questions about the study, and it's really great for us to be able to understand and speak back to some of the critiques and concerns. Thanks.
Yeah, Karen, you want to take that? Yeah. I'm also going to share Bodan's, so one of the other study leads. He spent like an hour going over this and how it was controlled for at each thing. The one thing I can say about the OAT dose was that people, the critics out there, were saying that people on RMG or prescribed safer supply were probably getting higher doses of OAT. Therefore, what we're actually seeing is the protective effect of OAT, not the protective effect of prescribed safer supply, because it was just higher doses, which Bodan addresses again in this recording that I'll paste into the chat and get Rebecca to send out, but it's not actually true. So people on RMG were on considerably lower doses of methadone and buprenorphine compared to those who were just receiving OAT. So that's, I don't know, Karen, do you want to speak more to the methods? But I can share this in here.
I got it.
Yeah, thank you. I do encourage people to take a look at the presentation that that Bodan gave last week, where he goes more in depth into exactly that issue. The short answer is no, it's not related to OAT dose. We have also followed up the analyses that were presented in the paper with additional analyses, just based on some of the questions that we've been getting. We've been attempting to try to be responsive, particularly to the expert opinion that comes from clinicians who work in this area, just to address some concerns. It does not appear that these alternative explanations, particularly around OAT, can account for the patterns of findings that we did receive. I'm not sure if that completely gets at your question, but you know, I do encourage you to take a look at Bodan's presentation, as he does get into that issue, and he's got a couple of supplementary graphs that I think would be helpful in illustrating some of these points.
Yeah, there was a couple I really appreciated. Also, there was a question that Bodan addressed in the presentation about how the looking at the next week and the doses, like on the treatment week, and looking at what happens the next week. That was really nicely explained in there as well. And I have put the link in the chat, and we'll also include it on the website when we post here. We can put a link to that presentation as well, because it's nice to have the different the different presentations. You talk about things in a slightly different way, which is really helpful. One of the things I learned in Bodan's presentation also was about statistical significance, and how even if something's not statistically significant, that doesn't mean that there's not an effect happening. It means that we need to have like more data, more time on all of those sorts of things. And I really appreciated the fact that this team has jumped in to do this, or who, like, you know, you did this work and are going to continue this, recognizing that we need information about this as quickly as possible, given how doing research is a time-consuming, it's a long process, and we're in the middle of an emergency. So how long do we wait before we start figuring out what's going on, what you know, why are things happening the way they are? I was really curious about how things might change as other medications became more available in BC. One of my concerns about evaluations of safer supply has always been that we are using Dilaudid, we're using hydromorphone tablets in the context of fentanyl supply and more, right? Now benzos as well. And so how do we assess an intervention when we don't necessarily have the right tools for that intervention, right? Like, so yeah, so
that's a really good point. And, you know, I think we talked about it, like, we're going to have to at some point control for like the level of fentanyl and the unregulated drug supply somehow in our research studies, right? And we have another paper that's under review and in the second round of revisions, but that shows that around OET retention, because we know in BC OET retention has been on a dramatic decrease over the past 12 years, that people who initiated OAT and RMG, or safe supply together, sorry, I'm just speaking in acronyms today, that they had much better titration and retention of OAT. And so maybe that's something we have to think about, right? Because the dosing guidelines for OAT were done before the fentanyl crisis, when it was heroin. And so, you know, buprenorphine and methadone don't work for most people as is. So maybe those hydromorphone tablets are kind of that adjunct. And Rebecca, to your other point, our updated cuts of data, and now that BC has expanded the medication formulary of what's in there, so that we've got sufentanil, Fentora, and the fentanyl patch, and quite a few people are getting the fentanyl patch. That will be included in our future updated analyses as well. So we'll be able to break out those new medications as the intervention evolves.
And I sit in on a lot of like clinician meetings where people are talking about prescribing practices and such, and talking about how to try to match people's needs with Dilaudid, with hydromorphone, and using an oat backbone, right? Cadian, and looking at those doses, adjusting those, because there's only so far you can go with the dilaudid. And so, yeah, again, so teasing out the OAT and the safer supply prescription piece. Yeah, it's complicated, but it's very clear that you've controlled for OAT and the doses in there. So, yeah, it's
And
yeah,
even with the OAT, we control that every week.
yeah.
So if you look at, I'm not going to go over Baudin's presentation because it's very heavy, but he goes over how, like, so we were matching people on their OAT receipt at those weekly time steps.
Yeah, it's great. The stimulants and hospital acute care visits is interesting. Do you have any thoughts about that? Why?
I
Just
really am unsure as to what is going on there. I'd be curious if anyone in the audience has any sort of inkling of why you might see this, such an association. Obviously, we know that acute care use within this population, there's many different pushes and pulls into and out of the emergency room, hospitalizations, reasons that people aren't seeking care, and it's just it's very interesting to look at. So Robin's suggestion, maybe people are staying awake longer and are therefore more likely to do something ER worthy. I love this. I like that kind of speculation.
So one of the questions I always like to ask people is, what surprised you in the study? And I think that might be one right there, right? That was a bit surprising. Were there any
For
other
me, yeah.
To be honest, the fact that hydromorphone tablets were protective, like we weren't expecting these findings by any stretch. So the fact that even though we know, from people with lived experience and the community that dilaudid are not meeting the needs of people who use fentanyl, there was still such a significant, robust dose response in the protective effect against mortality rates. So that surprised me.
Other thing I learned or relearned, I should say, my EPI's prof, in case my epi prof is on this call, I relearned it, was around dose response. And was watching again the presentation from Baudin, was he talked about dose response as indicating that this isn't about correlation not being causation kind of thing. Like this, it's showing that there is a causation kind of relationship here, not just
yeah, you get as close as you can to flirting with causation for an observational study. Like that's how I think about it. This is for sure.
Because we can never be absolutely sure. So what we try to do in the science that we conduct is to try to think of potential alternative explanations that could account for our findings. So if it's not the DILIs, what could it be? And then we try to rule out that explanation with our study design as best as we can. And it just, to echo what Brittany said, we were throwing at these models a lot of different ideas of what else could be accounting for mortality in this population, and nothing was sticking. So it's interesting, as we were trying to develop as a team what other potential what could be potentially going on here. We would just continuously come back to this, that there does seem to be a signal here. Whatever it is, it just there is a signal of a protective effect here that does appear to be robust.
Amazing. I also really appreciated that when you were talking about the characteristics of the matched group and the treatment group. Yeah, am I saying this right? Oh, I don't want to embarrass myself.
Yeah, no, that's good.
Qualitative.
Your epi prof would be so proud. Fine.
But yeah, that there's such a socially and medically complex group, right? And so this is a very population whose needs have largely been unmet through traditional OAT and even primary care situations. So yeah, I think that's an important piece for us to also to understand about when we talk about RMG prescribing or OAT prescribing. And again, the fact that it's reached 6% of the population, and a lot of that I think has been through because of like triaging who we're going to offer safer supply to at this point. And hopefully, you know, we can have it available to more people at a higher population level and reduce more risks, particularly amongst those, not particularly, along with those who are not diagnosed with a substance use disorder, right?
That's right.
That's a big thing. Mm-hmm.
It
Yeah.
is huge.
Yeah. And I think to your point, you know, critics have said, well, if safe supply is doing such great things, then why has BC experienced an increase in overdose deaths since 2020 when the pandemic hit and it was rolled out? And you go back to only 6%, less than 6% of people who had a stimulant or an opioid use disorder received the intervention. So you wouldn't expect it to have that kind of turning the tide kind of change. And, you know, I don't think you should expect that out of a medication.
Right. And
Also.
then when you look at the 5,882 people, how many of them had access to that prescription for more than a few days or a few weeks? Because that's the other thing
Yeah.
the truth is I hadn't really thought too much about, because the majority of the programs that I work most closely with are ones in SUAP funded CHC programs.
Yes.
That where retention is, you know, very high, over 80%, 90% in different places. And they're working with people for a long time, right? And so they're on the medications, on the prescribed safer supply, prescribed alternative medications for a long time, not just a few days out of, yeah. So yeah, interesting. There is a question here from Anjay. How can we translate or present the evidence and research conclusions in studies such as this, which illustrate the favorable outcomes of PSS, to the public in ways that encourage a greater level of understanding among the general public? How can we get the general public, my mother and neighbors and those folks, to understand? My mom does support safer supply, but very, very supportive. She's a member of the community practice, very good mom. But how do we increase general public understanding, particularly when there's such strong media that I feel like there's either strong media that's very critical, or there's a very balanced media that says these people are saying this, but those people say that. So yeah, how do we get the understanding?
I appreciate Amanda's parallel follow-up. Yeah.
Yeah, thanks, Amanda. Yeah.
As the communications officer where I work, thank you, Amanda.
A little bit
because Amanda helps us with exactly these topics is the communications piece. I know that as a team we have talked about this so much. How do we show up in the media in helpful ways? How do we not make the polarized discourse worse? You know, how do we avoid this study being used in political ways for gain, for, you know, for whatever political party it is trying to leverage support for their own ideas around how to respond to the toxic drug crisis? And it is really challenging. At a very micro level, we had some amazing communication supports from the media departments at our institutions who did get together to develop some resources related to this study, because we knew it was going to be a thing when we published it. And we have, so we'll share the links after this presentation for some of our social media products that we've been using with simplified little snippets from the study that we try to put out there. And it's difficult, certainly. And I think, as we all know, we are experiencing something of a harm reduction backlash at this moment, that is very, very troubling. And so we do try. We obviously, for those who, like Amanda and others who have communications experience, we rely a lot on support from these people with more expertise in that area to help us to convey these findings in a way that will change hearts and minds. It'll take some time.
Yeah, I would echo that and just say, like, to the BC CDC, because Amanda Sloan-White is the first author in this, like, their comms team did a very amazing job. So thank you if they're watching. The other thing is, like, breaking it down, right? Researchers aren't the best at talking about research. Some of us, I like to think I'm a little better. No offense, Bodan. So like infographics, plain language bulletins, research summaries, but all of us doing different parts, right? Like, I didn't want to rip apart the methods the way that Bodan did, because that needed to happen, but that he was the best suited for that. So I think some of, like, having an interdisciplinary team across different organizations with different networks, like Karen and Bernie are really linked in with the provincial peer network, and as am I. And so finding different ways to get the message out with different people, saying different parts of the message too, right? And if you take a pull back, we've got the whole thing. But yeah. And then besides that, addressing stigma, which is like all of our lifelong work for forever.
Truly, that is it too, Brittany. You really nailed that. That is what we need to do. And
because it's not about data and evidence most of the time.
Yeah.
As we found out.
Yeah. And I also, you say research is not always being the best at this. I think we're all being called on to learn more and more about communications these days. But we also get really stuck in the nuances of it all, right? And it's really hard to take very complex things and simplify it, because you feel like you're losing so much of either what makes it robust or what makes it interesting or what makes it, but I think having the simple pieces opens the door to the bigger conversations. And again, like, this has been so valuable, and I've learned so much more about the study, talking and hearing from you both. And thank you for that. And I still see the value for folks who are here on this call, listening to Karen and Brittany, to also check out Bodan's webinar as well, because it goes a bit deeper in some places if you're interested in those things. But I think I feel like I can walk away from speaking with you today with better understanding and better able to talk about what the study says and what it doesn't say, and what the implications are. And I think you right at the very beginning, Karen, you said that it shows that this is very promising approach to another tool we can add to the toolbox for supporting people who use drugs. And what we need for people right now are options.
That's right.
100%. Yeah. Nothing is a magical bullet. It's options.
Yeah. Also, we just have a minute left, but I'm curious. So you just got this new data on Monday. Very excited about this.
Hot off the press.
What is there a particular piece of is there a particular direction that you're really excited about adding into your looking into the data? Is there a question that you want to bring to it that you're really looking forward to? Or?
I am interested to see how the results compare as fentanyl medications are coming on board. And because they go to the end of 2022, we should start to see that based on what was happening in BC over the past few years. But I'm also hoping that we might be able to start taking a look at some subgroup analyses. So some analyses between different subgroups. As Brittany noted, we don't have gender identity, but we do have sex, and we are there is the potential, as the sample size gets larger, to to start looking in at some of these different intersections of identities around our findings, but
Yeah.
we shall see.
Yeah.
Yeah, one of the things I'm interested in is the geographic disparity, right? Because only 10 people or 11% of people outside of urban areas receive the intervention. So it'll be when we've got more follow-up, and it'll be interesting to see if that sticks, and doing some of that is really important. Yeah, we're meeting with the Ministry of Mental Health and Addiction, and some people in Victoria in the spring to start looking at how to redo and update these analyses and what we might look for in the next future. So we have a ton of stakeholder feedback on this project. So we've got project advisories that are going to chip in, and the Indigenous Advisory Committee will also talk to us about what they want to see. So yeah, more to come. Lots to come.
Lots to come. It's really an exciting time. There's lots of work happening, and a lot of momentum to keep figuring this out. So yeah. Thank you both very much. And thanks to everyone who attended today. We'll have this up with the paper and slides and all the other things, the knowledge products. Probably tomorrow. Yeah. Thank you very much, everyone.